the final and a major topic in neurosurgery which we need to talk about are brain tumors. Now, in brain tumors, first let's talk about the classification of brain tumors and then we'll discuss them individually in detail. So let's first talk about the classification of CNS tumors and then we'll talk about each one of them in detail. Now, if we talk about the classification of CNS tumors, you can have meningeal tumors, that is a meningioma. Then glial or neuroepithelial tumors. These are gliomas, which can be an astrocytoma. You can have a glioblastoma, an oligodendroglioma, or an ependymoma, right? Nerve sheath tumors, you can have a vestibular schwannoma or a neurofibroma. There can be embryonal tumors like medulloblastoma or neuroblastomas. Blood vessels can give rise to angiomas or angiosarcomas. There can be craniopharyngioma, which is a tumor-like condition. Craniopharyngioma, we'll talk about this. Pineal gland tumors. So these were all primary CNS tumors, right? In addition to this, you can also have metastasis, which in fact is the most common brain tumor, right? So if you're asked the most common brain tumor, it is actually metastasis. And I'll tell you which are the sites which can commonly give rise to metastasis. We'll talk about brain metastasis in detail separately, but I just wanted to cover the classification with you first. Now, irrespective of the brain tumor, the clinical features of brain tumors would remain common. So let's cover the common clinical features which you would encounter in a patient with brain tumor. So I will not cover them separately with the individual tumors. Now, patients will either present with a focal neurological deficit. So patients can come with focal neurological deficits. Or these patients can come with seizures. In fact, there is one statement which I want you to remember. Sudden onset seizures in an adult, you should always think about a tumor. Always think about a tumor. And why I don't forget this statement is because I have a very, very dear senior of mine who was diagnosed with an astrocytoma. And I will never forget that because, he had just finished his post-graduation in medicine and it had just been a few weeks and he was sleeping in his hostel room, along with two more friends were also there. And suddenly in the night around 1 o'clock, he started seizing. They rushed him to the emergency. They gave him all possible medicines, but he was in status epilepticus. And finally, when he was shifted to a corporate hospital, scans were done. It was found that he had a big tumor, almost a 5-centimeter tumor in the frontal lobe. Fortunately, he's doing well now. Of course, there are neurological deficits, but this is something which I want you to remember. Sudden onset seizures in an adult, always think of a tumor. These patients can present with features of raised ICT. So these patients can have nausea and vomiting. They can have headache, which is more in the morning. So these are the common clinical features which you would encounter. Now, depending on the location of the tumor, also patient can have particular features. So if there is a frontal lobe lesion, then that gives rise to more personality changes. Patient is going to have more personality changes. There is one syndrome which I want you to remember, that is Witzel-Schuss syndrome. And this is pathological joking, which is seen in a frontal lobe lesion. This is pathological joking, which is seen in a frontal lobe lesion. Okay. So these patients with frontal lobe lesions can also have antisocial behavior. There can also be antisocial behavior. Now, if it's a temporal lobe lesion, Temporal lobe lesions can give rise to psychosis. And if there's a lesion in the occipital region, visual disturbances would be common. So these are just indirect indicators regarding the location of the lesion. Now, how do we diagnose brain tumors? So this is across the spectrum. The investigation of choice to diagnose brain tumors is MRI. Right? We know MRI is better than CT in regards to especially posterior fossa and giving a more detailed appearance of these lesions. So MRI is the investigation of choice in brain tumors. And, the neurosurgeons work very closely with radiologists because a lot of these tumors are diagnosed just based on the radiological signs and the location where they are present. So this is the investigation of choice in these patients. Now, again, if we talk about the management options in brain tumors, so the management options for brain tumors would include surgery. And surgery helps us in two things. Surgery helps us in removal of the lesion. That is one of the aims. And it will also help us in histological diagnosis. For histological diagnosis, a stereotactic biopsy can also be done in select group of patients. So we can even do a stereotactic biopsy. Stereotactic biopsy is basically you put a grid around the head, and that helps us in localizing where exactly the biopsy has to be done so that there is no collateral damage caused when the biopsy is being done, right? So you accurately localize and just take the biopsy from that area and other areas are not impacted. So surgery is one option. Chemotherapy is given in select group of tumors. I'll talk about them. Radiotherapy is another mainstay of management of brain tumors. Now, radiotherapy can either be whole brain radiotherapy. You can either have whole brain RT, or there can be SRS. SRS is stereotactic radiosurgery. SRS is stereotactic radiosurgery. Questions regarding this has also been asked in the exam. One of the examples of stereotactic radiosurgery. So either this stereotactic radiosurgery can be a cobalt based thing, or it can be a gamma knife, right? This gamma knife term has also been asked in the exam. What exactly is stereotactic radiosurgery is what I'm going to tell you. So stereotactic radiosurgery is when you accurately localize the lesion and you have multiple precisely guided radiotherapy rays. So multiple radiotherapy rays, you can see here multiple radiotherapy rays, and all of them are converging at the target. So it is very precise. Again, the advantage is a maximum effect on the targeted lesion and minimal collateral damage is there. Whereas if you give whole brain radiotherapy, the entire brain is getting affected. So a lot of collateral damage, a lot of swelling to the brain, which you don't get in stereotactic radiosurgery. Where is stereotactic radiosurgery used? It is of course used when there are brain tumors or metastasis. Mainly for metastasis, it has a huge role. It is also used for trigeminal neuralgia. This has also been asked in the exam. It is used for trigeminal neuralgia, and it is again one question which has been asked multiple times for arteriovenous malformations. So please remember where all stereotactic radiosurgery is used in CNS: metastasis, trigeminal neuralgia, and arteriovenous malformations. I've told you what stereotactic radiosurgery is all about. Right, so I've discussed the classification, I've discussed the general clinical features of how to localize the lesion, the investigation of choice, and the various treatment options. Now let's talk about some of these tumors in detail. And the first one which we need to talk about are brain metastases. Now, as a breast cancer surgeon, I encounter a lot of patients who come to me with metastasis already or who develop metastasis later on. It's not a very good sight to see such a patient. the prognosis is also not very good. So if you talk about brain metastasis, these are the most common brain tumor. This is the most common brain tumor overall. That is metastasis. And the most common cancer which metastasizes to the brain, most common cancer which metastasizes to the cerebral or the cerebellum is your lung cancer. This question has been asked multiple times in the exam. But if you're asked the most common cancer which goes to the leptomeninges, it is breast cancer. So meningeal or leptomeningeal metastasis is commonly seen in breast cancer. So there can either be a solitary or there can be multiple metastases which can be seen in these patients. And if we talk about actual brain parenchyma, the most common site are the cerebral hemispheres, followed by the cerebellum. And these metastases are usually seen at the gray and the white matter junction. The investigation of choice to identify brain metastasis is MRI. And one very interesting thing which I want to tell you here is that PET scan is not a good modality to look for brain metastasis. That is why you know that triple negative breast cancers, I told you, triple negative breast cancers have a tendency for visceral metastasis. So triple negative breast cancers would go to the CNS, liver, lungs. So if we have a triple negative breast cancer patient, especially if the patient is complaining of headache, in addition to the PET scan, we always get an MRI done, because PET scan is not a good modality to look for brain metastasis. Okay. So MRI is the investigation of choice, and you will get these lesions at the gray and white matter junction. And MRI should be done with gadolinium enhancement. So it should be a contrast enhanced MRI with gadolinium enhancement, and you will see these lesions. There can be edema around the lesions. So there can be edema also which can be present around the lesions in these patients, and that can also add to the mass effect of these metastatic lesions. Now, we've already discussed the treatment, the general treatment of brain tumors, management of metastasis. So management of metastasis, role of surgery. So role of surgery is limited in metastasis. It is mainly restricted to if there is a solitary mets, and if the primary tumor is otherwise doing well. Right, so supposing I have a patient of breast cancer and there is a solitary tumor in the brain, no other mets elsewhere, and the patient otherwise is doing very well, the breast cancer is responding, then we can go in for surgery. Similarly, I've given you the example of Lance Armstrong in the testicular cancer module as well. He also had a lesion in the brain, and otherwise his lesion was, his testicular tumor was doing very well. So they went ahead and removed that brain metastasis. Okay. Then radiotherapy, I've already told you about whole brain radiotherapy, and I've told you about stereotactic radiosurgery as well. Chemotherapy has limited role. Chemotherapy has limited role except in patients with small cell lung cancer. Except in patients with small cell lung cancer or patients with seminomas, or intrathecal chemo can be done. Intrathecal chemo has a role in leptomeningeal disease. So triple negative breast cancer patients of mine, intrathecal chemo has a role there, right? Steroids, very important. Steroids are used to manage the raised intracranial tension, manage raised ICT which is there. And if you remember the head trauma module, I told you that steroids don't have a role in controlling the raised intracranial tension due to trauma. But steroids are the drug of choice when it comes to vasogenic cerebral edema. Vasogenic means, which is secondary to brain tumors, their steroids are the mainstay of treatment. Again, if the patient is having seizures, anti-epileptics are added. Anti-epileptics are added in these patients. So this is the treatment of brain metastasis which you should know, right? I have already told you these patients don't have a very good prognosis, and the disease tends to progress quite quickly. I would like to share one case where, there can be cases where patients present with no symptoms at all. And this is just a case which I picked up last month. This is a 27-year-old lady who came to me with a breast lump, which was approximately 4 centimeters in size, very hard. It was adherent to the skin, and she had been harboring this lump for the last 6 months. Because of lockdown, she never came for a clinical checkup. So, I did a biopsy. It turned out to be a triple negative breast cancer. And when we did a PET and an MRI, I was surprised to know that she had at least 6 lesions in the brain, but she was absolutely asymptomatic because of these brain lesions. So that can also happen sometimes, but unfortunately, she also has multiple mets in the lungs and the liver, so the prognosis is not very good. But what I want to tell you is sometimes these brain lesions can remain asymptomatic also. The worst is leptomeningeal disease. Leptomeningeal disease, I've seen a few patients of mine suffering from that. A, it is very hard to diagnose, and B, they progress rapidly. So it's just a matter of months when they develop leptomeningeal disease. It's a very sad sight to see such patients. So that was regarding metastasis. Let's talk about the primary brain tumors in detail now. Right. So let's talk about gliomas first, and then gliomas, astrocytomas. Before I do that, I just want to tell you one controversial question. Which that question is, which is the most common primary brain tumor? Now, different books say different things. Surgical books say that it is meningioma. It is meningioma more than glioma. But the pathology books say otherwise. Pathology books say it's glioma more than meningioma. Now, we've done extensive analysis on this, multiple references, and still there is no conclusion. Surgical books say this, pathology books say otherwise. Even latest Robin says glioma more than meningioma. So, just to settle this, I would just like to tell you that although surgery books are saying meningioma more than glioma, but we are going to remember that gliomas are the most common primary brain tumor, more common than meningioma. So we are going to follow this, and please forget this controversial question, but this is what all of us have collectively decided on, me, Dr. Rela and Dr. Rakesh. Most common primary brain tumor in children. The most common primary brain tumor in children. There is no controversy here. It is a medulloblastoma. And this is the most common malignant. So, to be very precise, most common malignant primary brain tumor in children. And you need to know that medulloblastomas are highly radiosensitive also. Okay. Now with this, let's start our discussion regarding astrocytomas. Astrocytomas, there are 4 grades of astrocytomas. The first one being a pilocytic astrocytoma. So these are the 4 grades. You have pilocytic astrocytoma. You have a low grade fibrillary astrocytoma. you have anaplastic astrocytoma and glioblastoma multiforme. So these are the 4 types of astrocytomas. The first one is pilocytic astrocytoma. Now, pilocytic astrocytoma, what you need to know, this is commonly seen in children, right? It is commonly seen in children, and it is the most common astrocytoma, as I've already told you, most common astrocytoma in children. This is a low-grade tumor. It is a low-grade tumor which is commonly seen in the posterior fossa, most commonly in the posterior fossa. And what I want you to remember is that in children, these astrocytomas are mostly in the infratentorial region, whereas in adults, they are in the supratentorial region. So most commonly seen in the posterior fossa. And the classical feature is that it presents as a mural nodule and there is no infiltration. Now, because it is a nodule and there is no infiltration, we can easily surgically excise it, and that's the end of it. We've already discussed that the investigation of choice is an MRI, and on MRI you will see a mural nodule. There can be a cyst associated with it, and there is edema also. So these are the classical features of a pilocytic astrocytoma, and the management of a pilocytic astrocytoma is surgical excision. We've discussed that if it's in the posterior fossa, this was covered in the general surgery modules. If it's in the posterior fossa, we prefer the Fowler's position. That gives you best access to the posterior fossa. And Fowler's position also, we've discussed the drawbacks of Fowler's position, the increased risk of air embolism, and we've discussed the various methods to prevent that air embolism as well in the general surgery modules. Okay. So this is regarding a pilocytic astrocytoma. You can see here, it's a slow growing astrocytoma, benign, and it is associated with the long-term survival. Now, low-grade fibrillary astrocytomas, they are again slow-growing tumors, and there are certain genetic mutations which can predispose them to getting converted into high-grade tumors. And what is that genetic mutation in low-grade fibrillary astrocytomas? You can have a P16 CDK N2 a gene mutation. And if this mutation is there, then that can lead to progression to higher grade. That can lead to progression to higher grade in these patients. So this is something very important to know about. And these tumors would be seen in these low-grade fibrillary astrocytomas are seen in young adults, and these patients usually present with seizures. The management is surgical excision. The third grade is anaplastic astrocytoma, and anaplastic astrocytoma, the patients are going to come with seizures, neurological deficits, which we've already discussed. So one more thing which I want you to know is that after surgical excision for a low-grade fibrillary tumor as well, whole brain RT radiotherapy is also given. We give radiotherapy in these patients as well. Now, patients with the anaplastic, that is grade 3 anaplastic astrocytomas, these patients are symptomatic. They would come with seizures, headache, there would be focal neurological deficits. In these patients, you get an irregular enhancing lesion. You can see here the MRI, investigation of choice is MRI, and you will get an irregular enhancing lesion. So irregular enhancing lesion is seen in these patients. And the management of these patients is surgical excision followed by whole brain radiotherapy. So that is the management of anaplastic astrocytoma. Finally, you have a GBM, that is glioblastoma multiforme, that is grade 4. This is glioblastoma multiforme. This is grade 4 and the most aggressive type of astrocytoma which is there. And in this, the clinical features we've already discussed. The patient is going to present with seizures, focal neurological deficits, and there is a rapid progression of symptoms in GBM. I unfortunately lost my very close friend's father to this disease, and it was in a matter of 6 to 8 months that from diagnosis till the time he passed away. So there's rapid progression, and the symptoms, you would see the patient deteriorating in a matter of days. So a very sad sight to see, and this is typically known as a butterfly tumor. So you can see it can cross the midline, go to the other side as well. So it can cross the midline. It is a butterfly shaped tumor. And what is important is that there is endothelial proliferation which is seen. The hallmarks are endothelial proliferation and necrosis which is seen in this tumor. And necrosis, these are the hallmarks of glioblastoma multiforme, and it would come as a ring enhancing lesion, a butterfly lesion. The management of these patients is surgical excision. So you have to do surgical excision, followed by whole brain radiotherapy. And what has really revolutionized the treatment, and in terms of revolutionize, I'm saying that it has added a few months to the lives of patients with GBM, is oral temozolomide. Which is the chemotherapy which is used in these patients. This has also been asked in the exam. It is also used in grade 3 patients. So grade 3 patients can also be put on oral temozolomide. This was regarding astrocytomas and the 4 grades you should know about. Let's talk about other glial tumors. The next glial tumor which we need to talk about is an oligodendroglioma. So oligodendroglioma is also a type of a glial tumor, and this oligodendroglioma, what you should know that there can be a chromosome 19q mutation is more common than a chromosome 1p mutation. And this is the genetic abnormality which can predispose to oligodendrogliomas. Now the good thing is that if these genetic mutations are present, then there is good response to temozolomide. There's good response to chemotherapy in these patients. So that is a good sign in these oligodendrogliomas. Now, clinical features, if we talk about, we've already discussed the basic clinical features of brain tumors, and these patients are also going to come with seizures. Commonly in the frontal lobe, frontal lobe patients are going to give rise to personality changes. This I've already told you. So there can be personality changes here. And the investigation of choice for these patients is an MRI. And when you do MRI, you will typically see calcifications, right? So this is the key thing. You will see calcifications on MRI. You can see here the calcifications. And which are the brain tumors which will show calcifications on MRI is also a question which has been asked in the exam. So the brain tumors which show calcification on MRI, craniopharyngioma is the most common. Craniopharyngioma is the most common, followed by oligodendroglioma, followed by meningioma. right? So these are the three tumors where you can get intratumoral calcifications. You should remember this. This has been asked in the exam. Craniopharyngioma most common, oligodendroglioma, and then meningiomas, right? The management of these patients with oligodendrogliomas, the management is going to be surgical excision as much as we can excise. So surgical excision has to be done, followed by chemotherapy. And the chemotherapy which is given in oligodendrogliomas is lomustine, procarbazine, and vincristine. And I've already told you, those tumors where mutation is present, oral temozolomide also does very well. Now, the questions which have been usually asked from oligodendrogliomas are related to pathology. The pathology is quite unique. You will get the fried egg appearance here. You will get fried egg appearance of cells. And this is basically the clear cytoplasm around the nucleus, the fried egg appearance. And you will also get chicken wire. You will get chicken wire vascularity in these lesions. So these are the two terms which are asked quite frequently in pathology: fried egg appearance and chicken wire vascularity. These brain tumor pathology has been covered in detail by Dr. Illa in her neurosurgery, in a neuro module. So you should go through that as well for more pathological details about these brain tumors, right? Now, the third type of glial tumor which we need to talk about is an ependymoma. Now, as the term suggests, it is tumor of the ependymal cells which are lining the cerebral hemispheres and the spinal cord. And the most common type of ependymoma is a myxopapillary ependymoma. And this myxopapillary ependymoma is closely related to the filum terminale of the spinal cord. In children, this commonly involves the fourth ventricle. Most commonly, the fourth ventricle is involved. And because, it's a tumor which is involving the fourth ventricle, and as the tumor enlarges, it will give rise to hydrocephalus as well. So that is quite a prominent feature of an ependymoma. It is associated with hydrocephalus. And it is common sense that, if you have a tumor lining the ventricle and it is, and that is the area from where CSF is traversing. So these cells can drop through the CSF. So there can be CSF metastasis as well. They can be spread through CSF. They can be spread through CSF, and this is very important because of this spread through CSF. That is why craniospinal irradiation is done in these patients to make sure that this check or this spread through CSF is kept under control. Now, on MRI, you will get a diffusely enhancing mass. You get a diffusely enhancing mass on MRI. And histopathology, if we talk about in this condition, you will get pseudo-rosettes. So pseudo-rosettes are seen. This has again been covered in the pathology modules. And the management of these patients is surgical excision as much as we can resect. Surgical excision, and that is followed by craniospinal irradiation. The reason for craniospinal irradiation, I have told you, is to keep the CSF spread under control. And that is another question which you should remember, that it can spread through CSF. So this takes care of all the glial tumors. We've discussed astrocytoma, we've discussed oligodendroglioma, and we've discussed ependymomas. The next tumor which we're going to talk about is meningioma. What you need to know is that these are extraaxial dural based tumors. Extraaxial dural based tumors. And these arise out of the meningoepithelial cells. They arise from the meningoepithelial cells of arachnoid. Now, if you talk about these tumors, these meningiomas are, if you look at the clinical features, they're more common in females as compared to males. And these tumors are, because they are well encapsulated, they're slow growing. So there is gradual progression of symptoms. A patient is going to come with motor deficit. So patient is going to come with motor deficit. There can be spasticity. There can be spasticity and there can be sensory deficit as well in these patients. Now, as I told you, the investigation of choice is going to be an MRI. That is the investigation of choice in these patients. It's a well encapsulated lesion. It's a well encapsulated lesion which is slow growing. Now, if you look at the MRI of these patients, there is a typical sign which you get on MRI, and that is the dural tail sign. You can see that this lesion, because infiltration is not there, this is going to give out these tail-like things which you can see on both the sides. This is the dural tail sign, which you see in meningiomas. This has been asked in the exam. And the histopathology also, there are two features which you should know. One is the whorled pattern on histopathology. You can see here whorled pattern on histopathology and the presence of psammoma bodies. This we've discussed in the thyroid module as well. Psammoma bodies, you know, are foci of dystrophic calcifications. One of the tumors where it can be seen is meningiomas. The other tumors, you already know, the other tumors where psammoma bodies are seen are papillary thyroid cancer. You can see it in papillary renal cell carcinoma, serous cystadenocarcinoma of the ovary, meningiomas. These are the tumors where you can see psammoma bodies, so you should know about them. You can see them here as well. The management of meningiomas is surgical excision. Management is surgical excision, and there is a Simpson grading. So I want you to remember this name. The Simpson grading is for meningiomas, and post-excision, this tells us about the recurrence rate or the prognosis as well. Grade 1 is when macroscopically complete tumor removal has been done of the dura and the bone. The recurrence rate, as you can see, is the least, just 9% here. 2 is when macroscopic removal and dural coagulation has been done, dura has not been removed, 19% is the recurrence rate. Complete tumor resection, dura not coagulated, 29%. Partial removal, 44%. And if there's simple decompression, then we are leaving behind tumor and there is bound to be a recurrence. So this is the Simpson grading. Again, the details have not been asked, the name has been asked, but those who are preparing for the INI CET exam, please remember this grading as well. Now, with the clubbing of these, all the central institutes, you also have the NIMHANS exam going through the INI CET. So you're bound to get some neurosurgery questions. They weren't there this time, but I'm sure in the future there will be one or two neurosurgery questions. So you should be ready with them because they can be the game changers in surgery at least. Now, the next tumor which we'll talk about is medulloblastoma. Now, medulloblastoma is the most common primary brain tumor in children. Medulloblastoma, I've told you, is the most common primary malignant brain tumor in children. It commonly occurs between 3 to 4 years of age, and it is commonly seen in the cerebellum. Commonly seen in the cerebellum. And medulloblastoma, if you remember the module where I've covered colorectal polyps and cancers, I've told you that this can be associated with Turcot syndrome, which is a variant of FAP. which is a variant of familial adenomatous polyposis coli syndrome. Turcot syndrome is where you get CNS tumors, and you know the other variant was Gardner's syndrome, where you get osteomas, sebaceous cysts, and desmoid tumor. But in Turcot, medulloblastomas are common. Meningiomas can also be there, but medulloblastomas are the most common. And you know FAP is with APC gene mutation on chromosome 5. It is a malignant tumor, I've already told you. And in children, I've told you that most of the tumors are infratentorial. So infratentorial tumor is there in the cerebellum. Patients are going to come with raised ICT. Right? Intracranial tension is going to be raised in these children. Ataxia can be there in adults if it is present. The investigation of choice is, of course, MRI. The investigation of choice is MRI. Now, features which are usually not seen in other tumors, and you need to remember them here. One is that drop metastasis through CSF. This we've also seen in ependymomas. Drop metastasis through CSF. This we've seen in ependymomas as well. But there can be metastasis outside the CNS as well. So Mets outside CNS. Mets outside CNS can be to the lymph nodes, bone and liver. So that is something which you need to remember. The management of medulloblastomas is surgery. But what I want you to remember, another question which has been asked in the exam, this is the most radiosensitive tumor, so responds very well to radiotherapy. This is the most radiosensitive tumor, responds very well to radiotherapy. This is another point which I want you to remember in these patients. And chemotherapy in the form of Carmustine, chemotherapy in the form of Carmustine and Vincristine is usually given if there is a recurrence. If there is a recurrence, then we use chemotherapy in these patients, and Carmustine and Vincristine is the chemo which is given. So this was regarding medulloblastomas. The next tumor which we need to talk about is acoustic neuromas. So acoustic neuromas, this is a nerve sheath tumor, and the most commonly involved is the inferior vestibular nerve. Followed by the superior vestibular nerve, more commonly than the superior vestibular nerve. Now, it is situated at the CP angle. So, it is usually at the CP angle, that is the cerebropontine angle. That's where this is situated, and commonly situated, and that is the reason why it gives rise to a lot of neurological symptoms. So, the clinical features, if we talk about the clinical features of an acoustic neuroma, the most common will be unilateral sensory neural hearing loss. Unilateral sensory neural hearing loss with tinnitus. With tinnitus, that is the most common clinical features. And in addition to this, you can have the 5th, the 7th, the 9th, so the 5th, 7th and 10th cranial nerves. Sorry, this 5th, 7th and the 10th cranial nerves can be affected, and you can get clinical features. The investigation of choice is an MRI, and this is a well-encapsulated benign lesion. It's a well-encapsulated benign lesion which is there. And the management is surgical excision. Management of these tumors is surgical excision. So this is regarding an acoustic neuroma. Now the next tumor which we need to talk about is a craniopharyngioma. Now craniopharyngioma is a tumor-like condition, right? If you look at the classification, it's been written as a tumor-like condition, and it's a benign lesion. So it's a benign lesion which is derived from the Rathke's pouch. Derived from the Rathke's pouch. And it is commonly seen close to the pituitary stalk. Close to the pituitary stalk with extension into the suprasellar cistern. With extension into suprasellar cistern. Now, craniopharyngiomas are commonly seen in children. They're commonly seen in children, but there is a second peak also which occurs, and the second peak occurs around 50 years of age. The second peak is seen around 50 years of age. Now, the clinical features in these patients. So, clinical features of raised intracranial tension. There can be vomiting. And because it is close to the pituitary stalk, you know that there can be visual disturbances also which can be there. So visual disturbances can also be seen in these patients. But in addition to these clinical features, which we've already discussed for all the tumors, these patients are also going to have hypopituitarism. So there's going to be because of the mass effect on the pituitary gland, there is hypopituitarism seen in 90% patients, and there is growth retardation seen in almost 50% patients. So there is growth retardation seen in 50% patients as well. So this is a unique feature which you need to know. Because of the pressure on the pituitary gland, hypopituitarism and growth retardation can also be there, in addition to the classical features which we've already discussed of brain tumors. The investigation of choice, MRI is the investigation of choice, then CT. We know that craniopharyngiomas will also have intratumoral calcification. Intratumoral calcification is also seen in these tumors. So this is something which you need to remember. In fact, this is craniopharyngiomas are the most common brain tumors which are going to show intratumoral calcification. Now, the management of these patients is surgery, is surgical excision, followed by radiotherapy. Is surgical excision followed by radiotherapy, and because you're giving radiotherapy to an area where the pituitary is also very close by, so after surgery and radiotherapy, these patients would require lifelong pituitary hormone replacement, starting with cortisol. Right, so we have to give cortisol as well, and because the pituitary is also affected with radiotherapy, you need to replace pituitary hormone lifelong in these patients. Let's talk about pituitary adenomas as well. This has been covered by Dr. Rakesh as well, but I'll just briefly touch these pituitary tumors mainly from the point of view of the management. So pituitary adenomas, they can either be functional tumors or they can be non-functional tumors. There can be a functional adenoma or a non-functional adenoma. Now, if it's a functional adenoma, it is going to have an early presentation because of the physiological effect. So there's going to be early presentation because of hormone release. So because of physiological effect, it will have an early presentation. Whereas if it's a non-functioning adenoma, it will usually have a delayed effect and it will just have a mass effect. And the mass effect can mainly cause visual disturbances There can be visual disturbances. You know the visual disturbance, the most common visual disturbance is bitemporal hemianopia. Right? So these are the clinical features. Now clinical features would depend on what is being secreted. Now the most common pituitary adenoma, the most common functional pituitary adenoma is a prolactinoma. And if you have a patient with prolactinomas, then these patients are going to come with amenorrhea, galactorrhea. Right. So I see a lot of these patients who come with whitish or milky nipple discharge, and we've diagnosed quite a few of these prolactinomas because of patients coming to me with this milky nipple discharge. Now this is commonly seen in the 3rd or the 4th decade of life. 3rd or 4th decade of life is when we see this. Now, when we are investigating these patients, we will, of course, if we are suspecting a prolactinoma, I do the serum prolactin levels. And one thing which you should remember, we always do pooled serum prolactin. Now, prolactin values are quite sensitive. So, a single value of prolactin is never quite sensitive. So, we do pooled prolactin. That means we take 3 samples at half-hour intervals, and then we club them together, and then we do the prolactin values. Now, if the prolactin levels are less than 100, then we usually don't think about an adenoma. But if the prolactin levels are very high, or if they are not responding to low doses of bromkriptin, that's when we suspect an adenoma. And if you're suspecting an adenoma, the investigation of choice is going to be an MRI. You should remember that if the MRI does show some lesion, you should do the entire endocrine profile to evaluate if it's really a prolactinoma or if it's some other functional pituitary tumor. The management of a prolactinoma, you know, if it's a microadenoma, it will respond very well to bromkriptin. Bromkriptin is the treatment of choice, and we usually give it for a period of 6 to 8 weeks. Now, if it is a GH, if it's a growth hormone secreting adenoma, then octreotide has shown very good effect. Octreotide helps in reduction of the GH growth hormone secretion and also the tumor volume. Now, first we need to know, this is the medical management, but when do we do surgery? So what are the indications of surgery in patients with pituitary adenoma? So the indications of surgery are, if it's a GH secreting, growth hormone secreting tumor, first you give octreotide, shrink the tumor, and then surgery is facilitated or it becomes easier. Or if it's a non-functioning tumor with pressure effects, if it is causing visual disturbances, or if it is not responding to bromkriptin, those are the indications for surgery. Now, surgery, you know that there are 2 approaches to surgery. But the preferred approach is transsphenoidal. Transsphenoidal is the preferred approach. This question has been asked many times in the exam, that you go through the sphenoidal bone and you remove the tumor. So transsphenoidal is the treatment of choice for these pituitary adenomas if you have to carry out surgery. What are the indications to give radiotherapy in these patients? The indications for radiotherapy in patients with the pituitary adenomas are if you have a recurrent lesion or if there is incomplete removal. That is when radiotherapy is reserved for those patients. So this was regarding pituitary adenomas, and this covers most of the brain tumors. One brain tumor which I want to cover is a primary CNS lymphoma. So this is also certain questions have been asked in the exam from primary CNS lymphomas. Now the incidence of primary CNS lymphomas is increasing because of HIV/AIDS. So increased incidence is due to HIV/AIDS and transplant recipients. Now, if we talk about the pathology of this primary CNS lymphomas, the pathology is usually a diffuse large B-cell lymphoma. It's a DLBCL. So this is a diffuse large B-cell lymphoma. And the clinical features of primary CNS lymphomas, again, the patient is going to come with raised ICT, seizures. We've already discussed these common clinical features for all these tumors. Now, this is a ghost cell tumor. This is a very important term which you need to know. It has been asked in the exam as well. Why do we call it a ghost cell tumor? Because it responds very well to steroids, right? So there is quick partial response. There is quick partial response to steroids because of the cytolytic effect of steroids. There is a quick partial response, and sometimes, you give steroids and you repeat the MRI and the tumor is almost regressed by half or more than that. So this you should know, these are ghost cell tumors. And this is one tumor where, surgery per se doesn't have a role. So, what we need to do is we need to confirm the diagnosis. So the diagnosis is confirmed by a stereotactic biopsy. Is a stereotactic biopsy. That means you put a grid and take a very precise biopsy. But one thing is very important. This biopsy, when you're taking the biopsy, steroids should be stopped before biopsy. Steroids should be stopped before biopsy, and I've already told you the reason why. Because if you keep on giving steroids, then what is going to happen? The tumor is going to shrink and you might not hit the representative area. So steroids should be stopped. And the management of these patients also comprises of steroids, intrathecal methotrexate. You need to give intrathecal methotrexate and cytarabine. So steroids and chemotherapy, that is followed by radiotherapy. That is the treatment for primary CNS lymphomas. So this takes care of the brain tumors which I want you to know about. So in this module, again, let me re-emphasize that trauma is the main thing which has been covered in the head trauma module. I have covered the cerebrovascular accidents, mainly Berry aneurysms, which I want you to know. The brain herniation syndromes are very important. The basic one-liners regarding brain tumors you should know. And the important ones, especially astrocytomas, meningiomas, those I've covered in details. Now, before I end this module, a few one-liners regarding spinal tumors as well. So you need to know that the most common spinal tumor is also metastasis. Most common spinal tumor are also metastasis. The most common primary spinal tumor are nerve sheath tumors. You know, you have nerves there. So nerve sheath tumors are the most common primary spinal tumors. The most common intramedullary tumor. So intramedullary tumor, most common is astrocytoma. So these are one-liners which you should know regarding spinal tumors. And that brings us to the end of the neurosurgery module. Again, those who are preparing for the INI CET exam, you should pay more attention to this module. Otherwise, those who are preparing for your college-based exams, focus mainly on the head trauma part. Even the NEET and the next focuses more on the trauma part of neurosurgery.